Health Beliefs, first reading. Ms. Bailey Crimmins. Oh, Ms. Polish, please.
Good morning,
Move
Mr.
the
Chair
microphone in front of you,
and committee
please.
members.
There you go. Thank you.
My name is Karen Polish, CalPERS team member. Agenda item number 8 is an information item, and it's going to be a continuation of our conversation and the development of the CalPERS healthcare beliefs. Today, the agenda includes our progress to date, the journey that we've been on, and a reading of the updated beliefs along with our next steps. I want to take just a minute to go over the progress we've made in the timeline. The team began our work last April and May with stakeholder outreach and a request for executive input. We then workshopped with the board at the offsite in July and provided draft statements for your feedback and consideration. We took that feedback and we workshopped with the executive team in August to further refine and update the themes and the belief statements. And then that information was used at our January offsite recently to workshop with the board and executive team to come up with these more refined beliefs that we're going to share with you today. And that brings us, of course, to today, which is the first reading of these beliefs. As I just mentioned, this journey started about a year ago. It's been an inclusive process, and we've been meeting with stakeholders all along the way. I'm going to spend a little bit of time sharing what we did in January, and then we'll walk through the refined beliefs that the team is putting through today. At the January workshop, the board and executive team were split into 4 tables, and we were given the updated, refined beliefs from the executive workshop, along with the themes and some scenarios to consider. So each team was asked to consider the beliefs in the context of some decision point scenarios, and the reason we did that was to help us decide whether the beliefs were appropriate and complete. After spending some time at each of the tables discussing the beliefs, each table reported out to the larger group through a flip chart and discussion. There were some statements that everybody agreed across the room needed some reworking, but then there was actually quite a bit of consensus and agreement around the room on the theme areas and the general belief statements. So today I'm going to walk through the themes and then get to the further refined beliefs after the January offsite workshop, and then I'm going to open it up for comments from you on this first reading version. Today's discussion and feedback is then going to be incorporated into an agenda item for April, where we'll be able to hopefully finalize and improve the beliefs. On slide 5, we have the 7 areas of theme areas that were actually brought forward to us through our stakeholder outreach. And we had consensus across the group that these are the right 7 theme areas. The only thing that we changed here is that we moved health program sustainability to the top of the list. While this list is not in order of priority or importance, it was commented that sustainability is foundational for the program, so it really should be at the top of the list. While we worked to update the beliefs after the January workshop, a couple of things caught our attention. We found some overlap and some redundancy in our beliefs. As an example, CalPERS has a set of core values. We noticed that some of the values were actually being restated in our healthcare beliefs, and restating the values within the belief statement seemed redundant and didn't offer the reader any real additional value or usefulness. So we removed the values language from the body of the belief statements and decided to create an introductory sentence to the belief statements as a whole. And that will help us tie together the core values with the work that we do every day and the healthcare beliefs. Looking at the attachment 1 of the agenda item, which is sort of a health beliefs one-pager, you'll see that this introductory statement is at the top there above the table, and within the table you have the themes and their associated belief statements. This is actually the anticipated format, more or less. We would have the introductory statement and then the theme areas with the associated beliefs to help people understand how they're being used. We also noticed in our work that we had circular logic happening within the belief statements. In some instances, we were unnecessarily restating the theme within the belief itself. It's a little bit like defining a word with the word, so we did some cleanup in that regard also. And since today is the first reading, I'm going to walk through each of the themes and the updated belief, including both the January workshop version and then the updated version. After I walk through all 7, we'll open it up for some comments and feedback. The first theme area is health program sustainability. So the workshop version reads, trustees, administrators, and all other fiduciaries must consider the long-term viability of the CalPERS Health Benefits Program when evaluating proposed changes, will be accountable for their actions, and must transparently perform the duties to the highest ethical standards. We had consensus across the room that this was way too focused on financial terminology, and that we didn't really embrace the theme of sustainability the way folks thought we should. So, and additionally, this is the belief that has the core value language in it that we removed and put at the beginning to cover all of the belief work. So after considering all the feedback that we got at the workshop, we went back and tried again, and we wanted to make sure that it was belief statement and not something that's action-oriented, but more belief-oriented. The revised version currently reads, the long-term sustainability of the health program is the foremost consideration when reviewing proposed changes to benefits, coverage areas, and costs. The next theme area is high-quality care. The workshop draft read, health benefit designs should help improve health outcomes by maximizing high-value care and reducing unwarranted care. We didn't really get a lot of actionable feedback at the workshop on this, but we felt that it was a bit instructional. It really talked about the how through reducing and maximizing rather than the why behind it, which is to improve the outcomes. So we did a little bit of work around that. We also noticed that we were falling into the trap of unnecessarily having the theme also embedded in the belief. So we took a look at that too. I don't know if you noticed, but in the first one, we say that for high quality care, we believe in high value care. They're awfully similar, so it seemed kind of redundant and a bit circular. So we did a little bit of switch on this one too, and we came up with health benefit plan designs must improve member health outcomes. For affordability, we had a lot of consensus across the room on this belief statement. The original one reads, health premiums and out-of-pocket costs must be affordable and sustainable for members and employers. The only thing we did here was to call out those two different stakeholder groups because they have different purposes. So the revised version is health premiums and out-of-pocket costs must be affordable for members and sustainable for employers, just for clarity. The next theme area is comprehensive care. And in the workshop draft, it says health plans should provide access to essential and complete health care, and members have a responsibility to utilize it. We actually got feedback from a couple of different tables on this particular belief statement. The feedback really was around them wanting us to emphasize the need to promote healthy lifestyles and promote healthy choices, as well as a need to state something in the belief about complete or appropriate or comprehensive care. So the refined statement currently reads, health plans shall encourage healthy life choices and provide access to essential health care and a wide range of health services. The next theme area is competitive plan choice. The workshop draft reads, members should have access to competitive plan options among health plans, benefits, and providers. This statement really didn't get a lot of chatter at the workshop, but we did tweak it a little bit to make it a little more comprehensive by adding the why portion. I think we should state in the belief why members need to have this competitive plan choice. So currently it reads, competition leads to favorable cost trends and increased value. Therefore, CalPERS members shall have access to competitive options among health plans, benefits, and providers. For the theme area of quality program administration, we initially had CalPERS is responsible for quality administration of all aspects of the health benefits program in order to meet the needs of stakeholders. For the most part, the tables were pretty much okay with this belief, but we did get some feedback, and it was around the idea of calling out customer service within the belief. We agreed with that, so we looked for ways to call out within quality administration the quality or the customer service component. So the current version reads, CalPERS shall meet the needs of its many stakeholders with responsiveness, accuracy, and respectful service. The last theme area is policy leadership and advocacy. The original version for the workshop read, as a leader in health benefit innovation and purchasing, CalPERS should engage in activities that influence health policies and affect the CalPERS health benefit program. So some of the feedback on this, we got a couple of good items. that we should be sure to call out state, local, and federal within this belief. And then there was also some talk about the need to call out the fact that we should align with like-minded entities in our work. So the refined statement currently reads, as a leader, CalPERS health program shall engage in activities that influence local, state, and federal health policy landscape and align with other entities who share our values. We thought that was a little more inclusive of the way that we really thought about our engagement activities. So after I've walked through all 7, gave you some of the reasons why we made some of the changes that we made, I'd love to open it up and get some feedback on the current version of the statements.
Thank you. We have a couple of requests to speak, but I have a question first on, I believe it's on your page 8, the high-quality care. The refined statement, health benefit plan designs must improve member health outcomes. How is that measurable?
It would be a population health measurement, but we can consider changing the word if you feel like it's too strong.
I think the must in there, I think, throws something in there different for me, because what if my health doesn't improve? It had nothing to do with the healthy plan design. So how do we use that word must and yet focus on the fact that it's going to improve for everyone, and it may not? I just want to be cautious that we're making a statement we may not be able to support. So,
Thank you.
Ms. Taylor.
Yes, thank you, Mr. Chair. So I'm kind of going to, I think I addressed these already, but I kind of am going to go through them as I marked them. The high quality care one, I agree with Mr. Fechner. I kind of think that health benefit plan designs must improve member health outcomes. The better statement is the other one. To me, health benefit design should help improve health outcomes by maximizing high value care and reducing unwarranted care. And I think that that can be tweaked. Or maybe you can just add a should on the other one. I don't know, but I think that help improve is better. Affordability. So the original was health premiums and out-of-pocket costs must be affordable and sustainable for members and employers. The refined statement, health premiums and out-of-pocket, and we talked about this. Out-of-pocket costs must be affordable for members and sustainable for employers. I'm still kind of stuck on, isn't it? I mean, if it's not sustainable for the employers, it's not sustainable for the employees, and that's part of the reason they get out of, when our public agencies leave. That's part of that reason. It's because the employees are saying, we can't pay for this, it's too expensive. So, I mean, it's sustainability for both, but I mean, maybe I'm splitting hairs, I don't know, and maybe the rest of the board doesn't agree with me. I think comprehensive care, I didn't really have a problem with that. Oh, come on. Am I losing the one that I really wanted to talk about? Don't you love it when you can't find what you're looking for? Sorry about this, guys. Somehow I erased it. Yay. I think it was the competitive, yeah, there it is. The competition plan choice. The original statement, members should have access to competitive plan options among health plans, benefits, and providers. And I think what we were thinking there when we were all working on that was that, yes, we agree that being able to choose your hospital and doctors is very important. Health plans that offer those those doctors' choices is what we want. You changed it to competition within our health plans, which isn't, I think, where we wanted to go with that. And I'm not sure that we have proof that that is a cost savings, or at least it's never been presented to us that there's proof of cost savings. And I think we did discuss over the phone when I had my briefing that I've seen research that shows that our cost savings have gone down as a result of the Affordable Care Act enactment, not necessarily the choice that we've instituted. So I'm not sure that I'm feeling good about that one because I also don't disagree with a single payer option. And I've said that before. And I know that's a long way off and that's not where we're at, but I think competitive model health plans, having so many health plans also lowers risk pools for everybody involved. It makes it smaller and it makes, to me, it doesn't necessarily make it as cost effective. So that's where I'm at on that one, and I don't know if I have any agreement with the board on that. I think those were all of them. Yeah, that was it. So those are my concerns, and I don't know how I have agreement with the board or not. Thank you.
Thank you. Ms. Mother.
Thank you. Well, first, I just want to thank you for the work on this. This is a very complex field, healthcare, and trying to come to a distilled set of beliefs is no small task. And you've engaged the board and the public and the executives and the executive team and the health benefits program, and to really come to, I think, a very strong set of beliefs. I do have a few comments, however. On the comprehensive care piece, I think, well, I guess what I'm concerned about is the wide range of health services, because I don't think we're in the business of providing any health service that anyone can imagine. It's really about evidence-based services that we think, that evidence shows adds value. And so I think it's a little too broad at the moment. And one suggestion might be health plans shall encourage healthy life choices and provide access to essential health care and a wide range of evidence-based health services or health services that add value or something around that. I think would tighten that up, would strengthen that a little bit.
Okay.
On the high quality care, so maybe I'm going backwards. I really liked having the high value care, maximizing high value care and reducing unwarranted care. I do think we have come to the belief that those are key to driving both healthcare affordability and improved health outcomes. They're not just any strategies that we think will work. And so I think embedding them into the beliefs is important. So I guess I would resist taking that out of there. Right. I think we could change, so whether should help is the right terminology or should drive to improved health outcomes would be better language. I don't, I can live with either one, but I guess I would stick with or closer to the original draft on that one. Okay. But again, really, really good work, and thank you for all of your efforts.
Thank you.
Thank you. Mr. Gillihan.
Thank you, Mr. Chair. I want to echo the comments of my colleagues up here. I know this is tough when you're trying to juggle input from so many different perspectives, and I think we're getting to a pretty good place. A few comments relative to the high quality care slide. I want to agree with the chair, the vice chair, and Ms. Mother. I think where I would land on this is I think the prior version was better, and I'm comfortable with that as written. But and with the respect to comprehensive care, I generally agree with Ms. Mother's comments on that one as well. And then with respect to the advocacy, can we go to that slide?
Yes.
The thing that stuck out at me was that local, including local, I don't know what local policy is set with regard to healthcare, and to the extent it is, how it would even affect us. So I was just curious about that inclusion. I like the state and federal aspect of it, but I just question the need for local. And so if you could explain, maybe I'm missing something.
We can make that change. It was just an attempt to be inclusive based on some of the feedback. And I believe that when we talk of local, we're thinking of our actual regional or California specific, but not necessarily at the legislative elevation, because when you think of advocacy, it doesn't only incorporate the legislation. There's so many things that are advocacy. So it can be us doing outreach even. That's local from our perspective. So if you feel like it's too many areas, if it's too focused by putting the local in, it's still something we believe in the larger sense. I think it's there. but it wouldn't hurt to remove it.
Yeah, my 2 cents is I just don't know how it affects us, and I wouldn't want us to get too diluted in our advocacy efforts when we should be focused on the ones that impact us. But that's all. But thank you for your work on this.
Thank you.
Thank you. Mr. Miller?
Yeah, I'm really impressed with how these have kind of evolved and devolved and evolved a little further. It's a few steps further every time, and I really like them. I could pretty much just about say, go. There's a few little things, like everyone else, that I think could be improved. And on high-quality care, just big picture, not so much a change to this, but to me, quality is something that's kind of in the eyes of the beholder or the customer. And so focusing on outcomes alone, 3 airlines, they all get me from Sacramento to Pittsburgh, but the quality of the experience can be dramatically different. The same might go for restaurants or healthcare. So that's something I think as an organization we really should be paying attention to. There's a lot more to the patient experience than, hey, they didn't kill me. Hey, great outcome. But as far as this specific statement, I think almost by just removing the word by and having it help improve health outcomes, maximize high-value care, and reduce unwarranted care might really make that go for me for high-quality care. And then finally, competition and choice are not necessarily the same thing. Competition also implies a lot of negative aspects and inefficiencies in the bigger picture. And so I'm a little uncomfortable with the idea that we just would make a blanket statement that competition leads to favorable cost trends and increased value. Ultimately, sometimes it can have detrimental effects and shake good providers out of the system based on costs and result in less choice for our members in the long run and less satisfaction. So I almost like the idea of re-looking at that whole idea in a way that we make sure we're not just purely focused on just accepting that as a given. Thank you.
Thank you.
Thank you. Mr. LaFaso?
Thank you, Mr. Chair. Echoing all the comments on sort of what a challenge this is. I'll be honest, as I saw this, I guess I saw all these getting increasingly high level. I know that's the purpose of this exercise, and to keep reminding me that this is a tiering structure from beliefs to strategic plan to business plan to individual initiatives. And when I look at it that way, there's not much to be concerned about. Clearly, there's a interest in amplifying our focus on better outcomes and high-value care. And as we saw in the last hour, the devil's in the details, and it will remain in the details. I think the one that intrigues me specifically that gets to my second point, which is really the 7th one, because the 7th one doesn't quite have the same superstructure of belief to strategic plan to business plan to initiative, because it kind of speaks to our advocacy efforts. And I know we've been struggling to sort of contain it. Originally, it was the benefit of the system, that it was the benefit of the member. Now it's aligned with other entities who share our values. But since the first 6 feed into the 7th, I do think Ms. Taylor's observation and a little bit Mr. Miller's on competition is interesting, because in essence, we do have sort of a philosophical grounding as fundamentally a managed competition-based entity. Clearly, that is what aligns us with our those other entities referenced in number. I guess that's true. I don't know if you don't believe in managed competition, you believe in price regulation or something else. I don't know if reference pricing is price regulation or competition, since you can still go to the higher non-reference price provider if you want to. It's sort of a philosophical discussion I don't have to have with myself at the moment. But it warrants thinking a little bit about what our approach to competition is, because really the big issue outstanding for me is what's the superstructure that governs the policy leadership and advocacy component in belief number 7. Because again, I still think we have a lot of issues here about how much we get in the federal reports, how we get feedback, and trying to preserve the flexibility of the staff to be agile on use of resources. That's the big outstanding one. I will say I appreciate the comment about local. On one hand, there are a lot of people trying to influence the healthcare system locally. Some examples are, local initiatives to impose higher charity care burdens on hospitals, or, local decisions on hospital districts that affect the provider network. I can't imagine we'd get bogged down in one of those, but I trust if there was one that was pivotal to something that was important to us, staff should feel free. So again, the bigger picture point is not getting bogged down in detail, but I do think the superstructure that supports belief number 7 still needs some thought, not in the wordsmithing of itself, but in the background.
That's an interesting comment, because some of the feedback on this particular one was that this one seems to be an outlier compared to the others. It's, in one of these things, like, what is it, 6 of these things belong together and one of these things is a little different. This is the one that's a little different, because it is a little bit more ethereal. And we do actually have business initiatives that fall under this, surprisingly enough, because we actually have a current business plan initiative that charges us to engage with the health plans in the community to help improve health outcomes. So it's very interesting that there is some of the filtering down through the strategic and the business plan and the initiatives, although it's not terribly clear to anyone who's not working right there with it. But yeah, I think we could probably take another look at this.
Thank you.
Thank you. Mr. Jones.
Yeah, thank you, Mr. Chairman. I'm not going to echo everything that has been said, but I thank you for the fine work on this initiative. I kind of, agree with Mr. Fechter about the must, and I think I kind of agree with everything Mr. Gillihan said except one thing, and that was about deleting local, because I think that remembering when the Los Angeles Community College District was trying to decide whether to join CalPERS health program, the board was asking questions, and I wasn't there, but they shared with me, what's the value proposition of joining CalPERS and what influence that we will have in terms of sustainability, hopefully, and cost measures, et cetera. So it does have an effect on local, specifically when they're not only deciding whether or not to join, but also to continue to be part of the health plan. So I think that's the only different agreement. Otherwise, I accept all of his recommendations.
Thank you. Mr. Slayton.
Thank you, Mr. Chair. So to build on what Mr. Miller was talking about on the competition, I think there's a modifier missing there. And so, it's either well thought out or well managed competition. So, something that defines that you've really thought through that we think through that before we just blanket say competition's the right thing. So maybe that's a fix for that particular one. I want to go back to the first one, health program sustainability. And I would suggest that in terms of healthcare, unlike pension, you take out the words long-term. It's really about sustainability, and that sustainability could be some year-to-year sustainability, particularly in terms of affordability and access for our members and our retirees who, they're not worried about, is it going to be here 10 years from now? They're worried about this year and, whether they can get the physician they need, et cetera. So I think it's really about sustainability that applies both in the short term and the long term. So that would be my recommendation on that one. Thank you.
Thank you.
Thank you. Seeing no other requests to speak, I have a request from the audience. Mr. Neil Johnson. And again, Neil, speak your name and affiliation for the record, and you'll have up to 3 minutes.
Neil Johnson, SEIU Local 1000. Overall, we think this is a pretty good document. There are a couple of things that various board members have mentioned that were also areas we had big problems or had some concerns about. The biggest one probably is the slide on competition, and unfortunately, fortunately or unfortunately, I've had the history of 25 years or 30 years of the PERS health programs and how there has been this change in philosophy on plan competition, provider competition, et cetera, over that time, and I'm not sure that we have any particular evidence that one method has been better than another. And then the other issue, I'm not really sure this is essentially a belief, but more a method of implementing other beliefs. So I think we would recommend you really think about eliminating it as a belief. Then the other issue deals with high quality care one, and I think we feel the workshop draft was a better or more comprehensive or better explanation of the belief than the current refined statement, notwithstanding whether it should be must or should or whatever. But the other one really, Mr. Miller suggested dropping out maximizing. I might suggest dropping out help, and such that it says design should improve health outcomes, maximizing health value care, and reducing unwanted care. Clearly, that unwanted care component has really been important in trying to hold down costs and improve outcomes. Part of the adoption of the VBID program is another way to really control or minimize the unwanted care. So, I would ask you to go, or whoever, to go back and rethink how some of these things are said. But otherwise, I think it's a fairly good document. Thank you very much.
Thank you. I do have another request from the board. Mr. Miller.
I realize that I may have been misunderstood or misspoke. When I made my comment about high-quality care, I was suggesting the workshop draft, we should take the word by, B-Y, out, and just make it improve health outcomes, maximize health care, and reduce unwanted care, high-value care. So just to make sure I didn't misspeak.
Thank you. Seeing no other requests to speak, thank you and your staff very much. This is a great product so far, and we look forward to seeing you come back with more.
Thank you very much. We appreciate all the feedback and discussion today. So we'll take all of the suggestions from today back to update the beliefs and bring it back next month for a second reading, and we'll give it another go.
Thank you.
Thank you.
Brings us to agenda item 9, 2019 to 23 Health Maintenance Organization Plan Solicitation. Ms. Donison.
Good morning, Mr. Chair, members of the committee. I'm here to report and update you on the 2019 to 23 HMO health plan solicitation, focusing on the contract, provider networks, and county coverage. The Phase 3 portion of this solicitation included a revamped 2019 to 23 contract, which we provided to Aetna, Anthem, Blue Cross, Blue Shield of California, HealthNet, Kaiser, United, and Western Health Advantage. And I do want to note that in the background of the agenda item, we did not include Sharp, but they're included. So we're very pleased to have them continue in the network as well. Regarding the contract, this contract builds upon existing provisions that require pricing transparency in the form of capitation and fee-for-service payments. It also reduces complexity through an 18-month true-up after each contract year of the financial services. It can, for the financial portion of the solicitation, the financial plan consisted of proposed administrative services fees and fees at risk for performance measures. And it also included information for Blue Shield and Kaiser Health Plan about their pharmacy programs. Overall, the contractual negotiations have gone well, and we are shifting the team focus to the 2019 rate development process, where we will continue negotiating the financial terms. Regarding Medicare, we will retain the 2018 lineup for 2019 so that it will continue to address the combo enrollment issues with the least amount of member disruption. Provider network coverage areas. Some changes are under consideration or for expanding or withdrawing from certain counties, as noted on page 2 of this agenda item. I would like to make one clarification about the Health Net statement on page 2. Health Net is considering withdrawing its Smart Care plan from Sacramento County, but it is not due to unfavorable provider rates with UC Davis. So I want to make that clear. Health Net's decision is centered around the increasing costs in Sacramento County and the acuity of the risk that they assumed in the last 2 years. I'd like to talk about Aetna, and I'm going to bring up a map of Aetna's service area. While they're bringing that up, Aetna would be a new carrier for CalPERS. It proposes an HMO plan that covers 30 counties, mostly situated in Sacramento, the Bay Area, and Los Angeles. The table on page 2 shows the zip code matches to the Aetna coverage area, which we have mapped and is here for illustration. I'd like to have us also look at the coverage areas for the plans continuing. So that is the coverage area for our HMOs for this solicitation, at least for 2019. Our next steps are to continue negotiations based on the financial terms as part of the rate development process. This concludes my report, and I'm happy to answer any questions that you have.
Thank you. Ms. Mother.
I think it would be helpful, thank you for your presentation first, but I think it would be helpful to understand by what criteria do we consider inclusion of a new plan? And what are the pros and cons? Do we want expanded service area, coverage area? If it's redundant coverage area, what are the pros and cons of including a new plan? Because it may be that it adds a lot of value in certain coverage areas where perhaps there's not enough coverage, they offer additional network, I don't know. But if it's just bifurcating a pool and giving us less negotiating power in a particular area, there might be some cons. So I think with respect to Aetna, which has such significant overlap with our existing coverage, I want to understand better what value does it bring to our plan and to our members.
And that's part of our ongoing evaluation for 2019. So
Great.
Your
So
points
that will
are
come
very
back.
well taken,
Okay,
and we
thank you.
continue to refine our analyses for all plans.
Thank you.
Thank you. Ms. Taylor.
So, thank you, Mr. Chair. Thanks for the presentation. I think I'm sort of on the same page as Ms. Mother. I didn't see on the table that you provided much of a significant difference of the areas that are already covered by our current HMOs by the addition of Aetna. So it doesn't appear that there's any significant difference. I mean, I think the highest significant difference was 90%, right? So, which brings me back to that competitive plan choice that we talked about earlier. Why are we bringing in another plan that's not bringing us more choice or more areas to cover, especially for our rural areas? And then we are actually doing what Ms. Mother said, we're bifurcating this pool. And I think that takes the risk pool and pulls it apart, and then we end up with higher costs because they don't have as many people they're insuring or as many healthy people. It depends on what the costs are, et cetera. But I would like to see if we even need to do this, and that is a concern of mine. But then I also had brought up earlier the HealthNet Smart Care. So that wasn't the case that you guys put in our books, that it was leaving Sacramento County due to unfavorable rates, and that's not the case.
It's part of the unfavorable risk that they received in terms of the enrollment that happened in 2017 and 18. So it's not related to the contract with UC Davis. It's just related to the risk that they have taken on in terms of Sacramento.
So you're saying that
Sacramento area, not
the
Sacramento
Sacramento
County.
area has
Yeah,
a
the
higher
region
risk
of
pool?
Sacramento.
It has a higher risk pool, is that
No,
what you're
it's
saying?
not a higher risk pool. It's just that for Health Net, it's a higher cost region for them.
Okay, it's a higher cost
Sorry
region.
if I wasn't clear.
Okay. And then the Anthem coverage for their Select was that also the same, or is it because they're
That-
dropping UC Davis?
Correct.
Okay, and it's because of UC Davis and them not coming to an agreement?
Correct.
Okay. So we don't have anybody taking place of those two health plans except maybe Aetna. We don't know that for sure
Blue
yet.
Shield, traditional, Anthem, HMO.
The ones that were already
Right, PPOs,
accepting?
yes.
Okay.
Yes, there's coverage for UC Davis.
Okay. And I don't know if you want to opine on what Ms. Mather and I were talking about, but if you are analyzing it already for whether or not you're going to keep Aetna in the pool or not.
Exactly. This is really an update on the contract provisions, not necessarily on the financial provisions. So we
Gotcha.
continue to look at our situation in terms of administrative services fees, performance guarantees, and first looks at what the 2019 rates are going to look like. So that has to be part of the calculus.
Okay.
And just for the board members that are fairly new, just how this works is every 5 years we come through a solicitation for HMOs, and we do the terms of the contract. The financial piece is the second phase, and then whoever passes that goes into the rate development process. So the decision on Aetna, they've obviously agreed to the terms, but there are several other checkpoints that they have to get through in order for this board to approve them as a plan moving forward on behalf of our members in June.
One other aspect of the 5-year solicitation is we do have provisions that plans can come forward in later years and make proposals that may be good and beneficial for CalPERS.
All right, thank you. Mr. LaFaso.
Thank you, Mr. Chair. Just a little bit in the same vein, can you educate me a little bit? Clearly, big issue we're all focused on is the somewhat inequitable geographic distribution of plan choices. Can you give me a sense as to how much we found ourselves in the driver's seat to say, hey, plan, we like you want to come participate in our pool, but we'd really, really like you to extend out over here, here, and here where we're trying to cover. And we're good over there because you'll probably be the fourth carrier, and from 3 to 4 is pretty good. But this county, that county, and the other county, pretty saturated, prefer, you stayed out of there just to not upend our pool. How pushy are we in that?
Every year, and this occurred in the last 5-year contract too, as part of the rate development process, we do go out and ask them to talk about different areas they are thinking of expanding to, and they do, and sometimes they contract, and they did that. It might not have been as noticeable over the last 5-year contract, but we're looking for, from my perspective, from the HPAD perspective, we're looking for options in multiple geographies in terms of HMOs, because HMOs are regulated by the DMHC. And so it's difficult to say, let's push further north, say into Glynn County, because the DMHC regulations just don't provide for that approach. So we do look at the networks, because it's not just about the plans, but also the provider networks. And part of that examination is not necessarily plan competition, but provider competition. So the providers are also, that are affiliating with these plans, competing for our members. Now, the beauty of our designs is that it's not really competitive based on HMO plan design, because our plan designs have been aligned and standardized. Our contracts have been aligned and standardized. So when we look at network coverage, we look at the mix of capitation to fee-for-service, plans that are more highly capitated, and that includes dual capitation that adds hospital capitation. That's desirable to us. So we look at mix of fee-for-service, mix of capitation, coverage area competition across California, availability of HMOs in specific areas. Not every HMO is in every area, so that's how we look at it.
Thank you. And my other question is, are the provisions for ACA taxes part of the administration fee, or should I just ask, what's the approach to ACA taxes in the new solicitation? Pay them if they're applicable, don't pay them if they're suspended for a year?
They're not, the taxes in the current 2019 ASF fees are they do not exist because they're not going to be charged. However, we do have provisions that should not necessarily these taxes, but future taxes come back, that we evaluate that as we would any other ACA provision in terms of how we incorporate it into our plan designs and our premiums.
And just for transparency's sake, are those subcomponents of the administrative fee, or are those standalone components in the rate negotiation?
Let me see if Ben or David want to answer that. Come on up here, Counselor.
And if that becomes a closed session question,
That's why I'm going to ask him to help me.
Yeah.
We would probably recommend that we would take that question up in closed session.
Okay.
Since it does do with financial stuff.
Please identify yourself.
Oh, I'm sorry. David Vandergriff, CalPERS Legal Counsel.
Thank you.
Thank you. Thank you, Mr. Chair.
All right, thank you. Seeing no other requests, that brings us to agenda item 10, summary of committee direction. Ms. Bailey-Crimmins.
Mr. Chair, I took 2 items. One is to investigate enhanced member capabilities to compare plan benefits. That was an action item we took. And the other is to provide the PHB quarterly updates on the VBID implementation starting March of 2019, because it's actually getting implemented January of 2019. So March will mark the first quarterly update.
Very good, thank you. Agenda item 11, public comment. We have one request from the public, C.T. Weber. Please come forward. Not here?
No, there is.
Oh, there we go. Thank you. Please identify yourself for the record, and you'll have 3 minutes for your presentation.
Yeah, my name is C.T. Weber. I'm a member of several of the organizations represented here today, but I'm speaking as an individual because I wanted to speak on an issue that I just read in the paper yesterday, and that was I was sort of disappointed to read that the CalPERS board has rejected the opportunity to divest from illegal arms dealers. To me, I think that's sort of an assault. Right now, the assault weapons becoming more available and faster, the ability to kill and wound more people is increasing. And there's a movement growing to restrict these killing machines. I know you have a fiduciary responsibility, but I think you also have a moral responsibility. And I think that these two are in conflict. And sometimes I kind of wonder about the fiduciary responsibility of CalPERS anyway, because we're in a little bit of a financial crisis anyway. So I just want to say that there is a thing out there called social investing. I'm sure you're well aware of it. But I think sometimes it gives greater results than some that I see we're getting today. That's it. Thank you.
Thank you. Seeing no other requests to speak, will adjourn the open session, and we will go into closed session in 10 minutes. Thank you. See you next month.